I'll just go over the history a little bit, and then I'll talk about what I have done, what UB has done, and we'll go over all that. The first multidisciplinary pain center was set up by Dr. Bonica in 1916, University of Washington. And by early 90s, there were about 100 nationally. And his whole thing was that chronic pain needs to be dealt with in a biopsychosocial approach, exercise, diet, medical and life strategies. Opioids did not, opioids played only a minor role. And he set up the first pain clinic in Seattle, Washington, multidisciplinary. He had occupational therapists, physical therapists, psychologists, social workers, and others. That was the first model of a chronic pain center. Now, what does chronic pain do to you? Pain leads to activity avoidance, progressive deconditioning, reduced activity, further deconditioning. So in chronic pain, you see this, whereas you don't see this in acute pain. So there are two main problems with chronic pain. One is physical deconditioning, and the second one is psychological deconditioning, which is there's anxiety, anger, fear, mood is impaired, enhanced perception of pain leads to mood and depression, and again, it becomes a vicious cycle. So these two cycles need to be broken in any chronic pain patient. I would dedicate this talk to my professor, Dr. Prithvi Raj, under who I did my pain fellowship. So in 1994, I joined the Millard system in 1983 when I started the acute pain service and the OB service in the Millard systems. But in 1994, I left anesthesia to focus on the Pain Rehab Center of Western New York, which was a multidisciplinary pain center in Buffalo. We had 3 fellowship-trained pain doctors, 2 psychologists, 2 physical therapists, occupational therapists. So we were doing what the way pain needed to be treated. And then what happened? Then we had in the late 90s, Purdue Pharma came up with writing opioids. And with their marketing strategy, most of the multidisciplinary pain centers closed because of that, because opioids were cheaper, they were faster, the patients were happy, the doctors were happy. We didn't know what was going on, and we were very short-sighted. But in this whole thing, what we ended up doing was we addicted a lot of patients to opioids. That was not the way to treat the patients, but we addicted a lot of patients on opioids. And in Buffalo, at least, it came to in 2016, one of the doctors got indicted, and there were 10,000 patients then were left to find other ways to take care of pain, and they could not. So a lot of them were switched to Suboxone, but the pain was not treated. So they still have pain, and they're still on Suboxone or methadone or some other kind of medications. So one of the main things with chronic pain is you really need to diligently go over their history and make a diagnosis. I have found that a lot of patients don't get correct diagnosis and they just keep taking the pain medications. I will just go over this the very quick. In 2024, there was a study from JAMA said that 15% of the patients 65 or older are on pain medication, 5% receive long-term opioids. Now, deprescribing is not easy. A lot of times patients will consider if they have symptoms like sleepiness, bad memory, falls, or if the family expresses concern, or intentionally they took too much. Now, the guidelines recommend that we wean the patients off, or if they have medication interaction. So in those conditions, this blue line shows that they will consider deprescribing. What I noticed was, I'm just going to go on 40 years of my pain experience. You know, when I started, we did not write any opioids. Then we wrote a lot of opioids. 20 years later, and then we are back to writing no opioids. So I have seen the whole cycle come back to how the way I was trained. Patient says that nobody really talked to me about the risk of taking these medications. We sign a opioid a form, and that's the end of it. And the patient's resistance to decreasing opioids, they have had a negative experience, so they don't want to be tapered. There's fear of withdrawal. So this is from the patient's perspective. From the clinician's perspective, patients can get they can get defensive, adversarial, they're scared to stop the opioids. Physicians are not taught how to taper the medications, very time consuming. And, they don't want to have fights with the patient basically. And patients seem okay, so let's just leave them the way they are. And there's no incentive. They come back every month for the pain prescription. So the way the chronic pain centers were set up by Dr. Bonica, it was independent self-management program. It's a chronic situation. So just like diabetes, hypertension, the patient needs to take care of themselves. And one of the main things is function is the main thing. It's not, so in spite of residual pain, their functional status should be maintained. So active treatments need to be taught to the patient, stretching, strengthening, physical exercise, and home-based and self-directed. And then send them back to the community. They can go to YMCA, they can start doing or set them up with some networks like work hardening, or there are programs now where they'll teach you computer tasks, computer training. All sorts of things need to be done so that they can get back into the social structure and they're not sitting at home. And if we can treat this chronic pain, then they will not change from acute to chronic, and we will have taken care of the chronic pain right starting out. So one of the things that I monitor when I used to see a patient was the oswestry score is what I used to use. What is their pain when they are doing all these activities? And there were 5, it used to total to 50, and I needed to see the trend that the number was going down. So I knew that they were getting better and the pain was getting better and the function was improving. So you need to monitor the functional status. That's very, very important when you're treating pain. I'm just going to quickly go through a couple studies that were done in Buffalo through the addiction department. They compared using buprenorphine and methadone in failed backs and pain. And they found that both of them, by converting the opioid they were on to these two drugs, they were able to improve their function, improve their pain, but they were unable to taper them off. And the same thing was another study. This they did with a pain physician in ECMC, where physical therapy, psychological therapy was used in addition to tapering of buprenorphine or keeping them on a steady dose of buprenorphine. But they had a big problem being able to taper down their medication. But if they consistently kept them on buprenorphine, they were able to get better control of pain. So these were studies that were done in the addiction medicine department in Buffalo. For me, nociceptive pain, I divide them into 2 parts. Muscular pain responds only to exercises. It does not respond to medications as well. And the other pain, skin, visceral organs, tendons, etc., to non-steroidals, neuropathic pain to antidepressants, anticonvulsants. Opioids is the last option. And I felt that most of the physicians do not focus on the muscle component to the pain, and that sort of gets left out. And myofascial pain is in primary physician's office, 30 to 40% have that. And when they come to my practice, it was about 80 to 90% had that. So I'll just go over a little bit about myofascial pain. We know that exercise helps, but nobody teaches the physician how to teach a patient how to exercise, and just handing out sheets does not work. Janet Trevel is the guru of myofascial pain. These are all the knots. You know, if you sit on the computer all day long, you'll find a lot of knots in your neck, shoulder area, and you can palpate them yourself, and they are painful. So she took care of President Kennedy, and she wrote those 2 books, and her whole thing was exercise, stretching exercises, and how to do them. She had 2 volumes on each muscle, how to take care of each muscle. But she could not really promote it as much. The drug companies had money and they promoted their drugs. So what is a trigger point? Now, trigger point is I will go over that a little bit more after I'm going to talk a little bit about the study that I did with the treatment of myofascial pain. And this was published in 2022. And, you know, we were using opioids in treating chronic musculoskeletal pain. In spite, there were no guidelines that helps the pain of musculoskeletal origin. So what I decided to do was I made some 3 sheets with lumbar, thoracic, cervical exercises that I would teach the patients when they first came to the office. So this was one of the non-opioid adjuvants that the patient would have. And then we monitored their function and their pain medication use. These are the sheets that I made for them. And I will send these, if you send the email, I can send these. And also there are videos on how to teach the patients and how to, there are videos that the patients can follow and do them themselves. I don't have time to go over them for this presentation, but I will send all that. So we,
Dr.
so
Bansal,
what I did, yes.
If I can just also share, our office is going to take Dr. Bansal's presentation, both the video recording of today and her slide deck, and it will be available on our website.
So these were all workers' comp patients. There were 453 of them from 2016 to 2019. Out of that, 206, I was able to, they were part of the study, and they had to be on opioids for greater than 1 year, and they could not have any substance use abuse disorder. We lost 142 patients right away in the first 3 months. Because once you start teaching them exercise, and they just found another doctor. But 64 patients we were able to follow. And out of that, and we had various diagnoses, lumbar, cervical, you know, it was run-of-the-mill, non-cancerous diagnosis. Now, if you look at this slide, you can see that the age under 30, there were 6 patients. These are all working group of patients. They should all be working. Once they get on opioids, very few are working. And how many years were they on opioids? I had one patient who was over 30 years, 20 to 29 years. So you can see a lot of them are on opioids for many, 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 many years, more than 5 years. And blue line is what they came with, and the red line is what they went down to. 84% of the patients decreased their opioid dose, 34% were completely weaned off the medication. As you can see, before I saw them, they had done all the right things. They had gone, seen a physical therapist, pain physician, surgeon, they had surgery, they were doing exercise, but in spite of that, they were still on all those opioids. So after giving them the exercises, what I found was the muscle spasms decreased, the dose of benzodiazepine decreased, muscle relaxant dose decreased, and 20 had improvement walking. So their function was improving. So 80% of the patient had received care. So they were doing all the right things. So when you tell them that, hey, you need to start doing exercise, I say, hey, I was seeing all these people and nobody told me all this. And one of the main things that I found was the interventional procedures went down from 72% to 25%. So I was doing less interventional procedures. Also, I was able to send back 5 patients back to work, full-time work, which was, again, a lot of progress in a workers' comp patient. So we got a second prize in American Society of Regional Anesthesia as a poster presentation. Okay, so what are the myths about teaching exercise? It's very time consuming. I'll send them to a physical therapist, but the copays are too expensive these days. Insurance companies cover only 10 sessions, and a lot of primary physicians said the patients only want pain pills and they will not do it, which I did not agree with. So this is one of the patients I'm teaching. And it literally takes a minute to teach these exercises. It's easy to explain because you already know the patient. I'm going to go over 4 case studies. This was Jessica, 34-year-old, hurt her back in 2005. For 7 years, she had 2 back surgeries. She had radicular pain going down the leg. No physical therapy, no exercise program. She was on 20 milligrams of oxycodone, 15 milligrams of 20 milligrams of oxycodone ER, and 15 milligrams QID of oxycodone Valium. She was not doing well. So she was started on a stretching regime, followed by TENS unit, physical therapy. She was off opioids in 7 months. And she was married, bought a house, went back to full-time work. She's off the opioids. And this is her last year doing yoga exercises. She's off the pain pills. I saw her in 2017, and she's still practicing yoga, and that's what maintains her. And I like to put this slide in. It's a very busy slide. This is the PMP, which shows that patient, as she started to improve, she gradually weaned herself off of the medications. So I give them control so they can do the exercises at home. Once you teach them, they can start doing the exercises at home. They start to feel better. The myofascial pain gets better. Any stretching makes you feel better. And then they gradually wean. If you give them control, they don't have the apprehension that, hey, the doc will cut the medication off and I don't want to go back. So if you give them control, they will start weaning themselves off. This was a lady with stasis venous ulcer. Again, she was on hydrocodone 20 years prior, and then she was sent to the addiction specialist who put her on methadone. And she was on that for 15 to 20 years. And second to that, she was bedridden. She had that big wound ulcer. She was going to the wound clinic. She had anxiety. She was using a cane. She had weakness. She was in bed most of the time. So all we did was treated her with back exercises, biking, peddler bike to improve the circulation, wound care. She got more active. She started to wean herself off. She's back to work. She could walk on a sandy beach first time. She couldn't believe how excited she was when she went to Jamaica. And this is how her leg is. And, she is really doing well. All these narcotics wreak havoc on your immune system also, and that also affects the healing. And as you can see here, she started with 120 pills, and she gradually weaned herself off. It took a year and a half, but she weaned herself off. The longer the patient is inactive, longer on opioids, the gentler the starting program has to be. This lady, again, a 32-year-old, seen around 2017-18. She was 18 when she had dental work, and she got hooked on opioids. She started buying street drugs, methadone, then she went off and got on a methadone program. She had 2 back surgeries. She was depressed. No physical therapy. She had 1 epidural. Somebody told her get a spinal cord stimulator, but she could not pass the psychological depression test. So she was referred by the addiction specialist. Exercise physical therapy was started. Did the injections, got her on an exercise program. Depression got better. She had a permanent spinal cord stimulator placed. She's back to full-time work. She's weaning off, but she said, I can't wean off. And she went back to addiction medicine. So the whole thing here I'm saying is we worked with addiction people. She's back to full-time job. And that was the good part about this whole thing, that although she is still on methadone, but she was able to get back to a full-time job. Now, this man had groin injury in 1983, and he was placed on morphine, 300 milligram acupuncture. He was bedridden for 20 years. So he had a neuropathic pain, so burning, diffuse pain in the groin area. And neuropathic pain should have been treated with anticonvulsant, but his physician was treating him with morphine, which was not working. And as soon as I saw him, started him on Lyrica, which is anticonvulsant, he gradually weaned himself off in almost like 4 months. And he is still on Lyrica. He walks 20 miles a week now. He does exercises, went back to physical therapy, started driving. And this was a picture taken last year. He loves to walk. So, you need to diagnose. So what I have found is many a times patients don't get diagnosed, and, they keep coming to the doctor's office and prescriptions keep getting renewed again and again and again. So you need to give patient modalities to decrease the pain and control their weaning as the pain decreases. Now, what is myofascial pain? These are trigger points that develop in the muscles. And the one thing about trigger points is it radiates pain. There's red dots. So I'll show you some pictures about that. So that's how trigger points look. And you can feel them. You can inject them. And opioids are not indicated for myofascial pain. So as you can see here, these are the trigger points, especially if you're sitting on the computer all day long, and it radiates pain. So it's a very diffuse pain that it radiates. And I'm going to very quickly go over these, how it is radiating pain with the trigger points, especially after a car accident. You see a lot of trigger points that develop, and they radiate pain. And you can treat them with narcotics, like a lot of them get treated. Simple exercise in the shower, get them moving, improve the posture. So this is back again. It's radiating pain. The big thing about this is there's no numbness weakness. So even if it is radiating pain and there's no numbness weakness, then it is myofascial, needs to be excluded. So this is what happens. What is wrong with me? And they don't get diagnosed. They get shuffled. One of the things that I want to really emphasize is you need to take the whole body as the problem. The guy who had the groin injury, he was deconditioned, and his whole body was deconditioned just because of the groin injury. So you need to treat the whole body and not just focus on the groin itself. And same thing, somebody has a short leg, there's pain here, then pain develops here, pain develops here, pain develops here. So you really, really need to treat the whole patient. You can't just treat one part of the body in chronic pain. In acute pain, you can just treat one part of the body and say, okay, that's where the problem is. Especially car accidents, with the seat belts and the airbags, there's a lot of trauma from the neck down to the low back, and they develop a lot of myofascial pain, and the muscles go up and down. So home exercise program daily. Opioids, muscle relaxant, trigger point injections are not the first line of treatment. And we know that 95% of the back pain improves with exercise and physical therapy. So please use that as the first line of treatment. And a lot of patients can't afford physical therapy anymore. So that's why I like to teach them the exercises myself. And you want them to return back to work. And there are programs like Work Hardening and Access VR, which will guide you to return back to work if you're disabled. Also, they have programs called Access VR. In elderly posture correction walker, you give a patient a walker, that's what happens. This is a cane, the self-explanatory. They develop pain up there. Posture, if the posture is bad, you need to take care of that. All that can cause pain. So there are simple things that can be taken care of. Now, the reason I put this slide up here is that pain can be treated in different ways, and you need to find your own slot. Now, if you send a patient to a pain doctor or a pain nurse practitioner, you need to see what is the training? Are they only writing medications? Are they only doing injections? Are they monitoring the function? If they're not monitoring the function and if they're not improving, then you need to find somebody else. Have they missed a diagnosis? So, I taught medical students, these are medical students, how to do the exercises. And I used to have Sam used to come and talk to the medical students about how it is to live with pain. For 20 years, 25 years, he had pain. He and his wife would come and talk to the students, and it made a difference in the teaching, just with them talking about how chronic pain affects their life. So you can't just blame the pharmaceutical companies, blame the patients. You really need, and don't treat them like addicts. You really need to take care of their pain. Now, this study was done again in UB, and it was done by the emergency room and UB orthopedics. And what they found was person with the chronic pain has 2 times more mortality compared to pain-free. And high impact chronic pain is somebody who has major activity restrictions such as work, social, or self-care. They have 2.5%. So now they are trying to say that even chronic pain, the mortality rate increases. And this was just a statistical study, and a lot of these patients are between 55 and 60, white, older adults, females, married, residing in the southern region. They had the worst results. So what is the solution? I feel that 80% of the medical curriculum needs to be, there's lack of formal education. Graduate healthcare programs need to redesign and update pain models, emphasizing evidence-based practices. So this is the solution. So this is my mother at age 89. Every day, till 1 week before she passed away, she had to do exercise. Otherwise, she used to be in pain. She has such severe arthritis. So even my mother, I made her do things, and she looks happy. So this is what we are planning to do is I have a seed funding that pain can be treated in 50,000 ways. And I would like the UB faculty to come up with a proposal or research grant on how they can improve the education, how they can improve treatment of chronic pain. And I think this is where I'm going to end. Jill, you want to continue with whatever the funding and all that?
Sorry, I was just in the middle of trying to attach the file for everybody. First of all, thank you, Dr. Bansal, for your remarks and the talk. I'm not an expert by any stretch in the field, social scientist, but I always learn so much from these, and your experiences and what you've done across the field is very inspiring. So at this point, I'll open it up for questions. If anybody wants to pose anything to Dr. Bansal while I work to put the file that we have for her seed funding opportunity into the chat. Like I said, we will be sending it out later today as well. But after any questions, I can go through the key dates of the application and the process in regards to that. So does anybody have any questions for Dr. Bansal?
Yeah, can I ask a question?
Yes,
Hello?
yes, please go ahead.
Yeah, this is Dr. Gary Wang. Hi, Dr. Bansal, how are you? This
Good, good.
is long time didn't see you. I know you
Yeah.
are retired. I just want to follow your step. So, but we in our community, we do not only have underuse our therapy treatment, we have a lot of issues. Overuse the opioid medications. In the past few years, I have to very hard struggling to help people get rid of opioids. This kind of patient, if continue on opioids, there's no end of the pain. So my treatment way is I'm going to apply Dr. Bansal's grant to go write the article. I have more than 1,000 cases. I successfully winning off the opioids. But this is a lot of, I fully agree with Dr. Bansal's suggestion. There's a lot of things we need to do. But the one thing is we, in our community, we just feel the duty. We feel the punishment from the FDA. We do not feel just have in our primary care setting, if a patient, okay, it's 3 months less of the pain medication, I just go ahead and give them. If you have operation, you have these people just go ahead and give the opioids for 3 months. After 3 months, go to see Dr. Bansal. So in this kind of situation, we need to actively we need to have some to summarize our successful study cases, and need to give a strong information to the community. The opioids cannot be continued this kind of way. For my opinion, chronic pain do not indicate to opioids. Period. But
It all goes to the education.
How many people is on the opioids? If you give no matter what your therapy, I'm a rehab physician, I know, no matter what kind of therapy, what kind of treatment you give, no matter how many trigger point injections you give patient, no matter how much exercise you train patient, if you continue opioids, the pain will come back 100%. So that's my way to get rid of opioids. I put the patient on the everybody discontinue short-acting opioids, put patient on long-acting opioids and weaning off gradually. I found this one way we can go to use is to use the methadone liquid, because methadone pill is a minimum pill is 5 milligrams.
That's what I did say, that methadone works too.
Yeah, right. If I agree with you, that's but I advocate to use methadone liquid. If you decrease the liquid half cc, half milligram, patient do not fail. If you decrease the patient methadone half tablet, patient will feel significant on the bounce back. You will fail of the treatment. So that's why I think I usually give a methadone at the same time. This prolonged chronic pain patient, majority of people has the post-opioid using mood disorder. So this patient become very anxiety, nervousness.
Hey,
So
Dr. Wang, can we talk later on? Can we give somebody else a chance? We'll talk.
Yeah, I think this patient, I gave the patient SSRI. At the same time, give the patient clonidine. And then each case, but sometimes I send it to patient to therapy. Sometimes too late. If people do not go send the therapy, people do not tolerate therapy or do not want the therapy, and they always come back to complain. The therapy making me more pain.
Thank you, Dr. Wang.
So what my way to do this situation is I just,
Dr. Bang, can I talk to you on the phone later?
yes, okay.
Okay.
Okay,
Let's
thank
give
you.
somebody else a chance.
Yeah, so I see Dr. Nielsen has her hand up.
Hi, Dr. Bansal. You know, in the study that you did of your patients that you and Dr. Blundell published, you made the point early on as you discussed them that a whole bunch of them didn't stay. They didn't want the trouble to go through this.
Yeah.
So do you think that the problem here is the education of physicians who then see these patients, who tell them what to do in terms of treatment? Is this a medical education issue, or is this perhaps also a broader issue of, you know, in America, you know, we fix everything with a pill?
You know, this study was done, unfortunately or fortunately, from 2016 to 2019. And we had the crisis in 2016 from the physician who was indicted. And most of the patients were from him that left. And it took them at least 3 months to find another physician. You know, there was so much problems getting, and they didn't believe that exercise would help. You know, at that time, the patients did not believe that it could help. And so a lot of them left from, they said, is something wrong with you? I have pain and you want to give me exercise. And that was literally, and you know, they wrote nasty things about me on those Google reviews and all that. But you know, I knew that that's how it is. And so they left. That's what happened. So, but now when they come later on, like even last 5 years when I was in practice, they don't want to be given opioids. They come and tell you, please don't give me opioids. Because they were not educated. Patients were not educated. They were on a steady stream of medication for so many years, and they seem to have done okay. So it was lack of education for the physicians. Primary didn't know. We didn't know. You know, I prescribed medication. I won't deny that. You know, because you know we were bamboozled by the drug company. If we didn't write it, we were doing malpractice. So that's why I call it iatrogenic pain, because we created this problem. And so that's why education is very important. We need to, you know, I started teaching the medical students, family practice residents, they used to rotate with me. I said, anything I can convey to anybody. I went to primary physicians' offices. I said, just start the simple things and take care of the pain that you can take care of. Then you can do all the informational stuff that is different. But simple stuff, back pain is exercise, stretching, strengthening. That's the fundamentals. 95% get better.
So I want to thank you for being a pioneer and helping us understand this.
You know, I still have a lot of work to do. We have a lot of work to do. Let's put it that way.
Thank you for the question, Dr. Nielsen. Emily, you have a question? Go ahead.
Hello, so thank you, Dr. Bansal. I'm a medical student, so I'm not quite at the level of knowledge of all of you here. But I am very interested in chronic pain, and I'm interested in your thoughts on if acupuncture or CBT, for instance, are additional ways that we can help patients with chronic pain in addition to exercise.
You know, I use anything and everything that's non-opioid. Everything works because acupuncture has been there for 2,000 years. It has worked. So we should use that. Anything that the patient feels that helps. And there's a lot of psychological issues with chronic pain. They develop whether you like it or not. And so CBT is, you know, all these things help. I use all this, but you know, the talk was too, you know, it was only 40 minutes. So it, you know, I couldn't get into all those things.
Thank you.
So Dr. Bansal, I just wanted to share a couple of comments in the chat. So Jade Malco from the University of Rochester said, as the Associate Director of Opioid Safety at U of R, I want to applaud this effort in Western New York to improve clinician education around safe opioid prescribing and access to multimodal therapy for chronic pain management. And that's from U of R. And also another comment from Dr. Kelleran, who is here at UB, saying, thank you, Dr. Bansal, for a great talk as usual. So without any other questions, I did want to get back to highlighting this amazing opportunity that Dr. Bansal has brought forward for UB faculty. I attached the RFP in the chat. I said it will be going out later today, but we have set a due date for applications to be submitted to my office, and our team will be coordinating here by June 2nd with any teams that are selected to be notified by end of August and early September, where an announcement will be made formally. So it's a wonderful opportunity. This is the first time that we've done something like this through the generosity of a philanthropist. And as many of us have recognized and discussed in individual conversations, the timing couldn't be any better. Dr. Bansal, I think not only to support the vision that you have for this field and the research, but also based on the circumstances that a lot of investigators are navigating right now. So it would always be appreciated, but I think even more so at this point because of the challenges that everybody's navigating. So any questions can be directed to my office. In fact, my office. So jill.a@buffalo.edu. Please feel free to send any questions along to me. And I think we've actually highlighted that in the seed funding announcement as well. So feel free to reach out. Dr. Bansal has been amazingly accessible and has been super engaged in not only the preparation for this, but also in envisioning what she sees the seed funding really stimulating. So please make sure that if you have questions, I'm happy to connect you with her or answer any questions that you have. So Dr. Bansal, thank you so much again for the talk.
If anybody wants a talk given to them, I can personally give it wherever they want, whenever they want, in their office, to their staff, to anybody. Anybody wants to learn anything, I'm available. I'm retired now.
and extremely generous as always. So thanks to each of you. Oh,
yes.
Dr. Bansal, are you still in the office?
No, I'm retired.
Yeah, I know your son is in the office. Sometimes I try to call you.
Yeah.
Yeah, I can send.
So how can I contact with you? How can?
I'll call you.
Yeah.
I'll call you.
Okay, please.
Okay.
716.
I'll call your office.
Okay.
359-5143.
Thank you to each of you for taking the time to join us today. I'm very excited to work with any of you in the future who are going to take advantage of this amazing opportunity. So thank you, Dr. Bansal. Truly appreciated on so many levels.